This week on the BackTable podcast.
What ended up happening with that is then there's a group of people who are coming into our waiting room at the same time every week for 6 weeks. I'm talking about like dinner clubs, text buddies, like
they make friends.
Yes,
that's great.
Because again, we're not having the experience that these patients are, and it's so incredible for them to have someone who understands what they're going through to some extent. And so it just makes the whole day flow in a whole different way. It sets the vibe completely differently. And I have found that even when we're just doing pair-offs with a little bit more space in between, even that wait time is they get to know our front desk really well. They get to know other people coming in regularly. So there's different ways to do each, but what I have found is that it becomes most effective because we are working all together.
My name is Ruchika Talwar. I'm a urologic oncologist at Vanderbilt in Nashville, Tennessee. Today, I am joined by Meredith Donahue, who's a nurse practitioner with a focus in urologic oncology, and Brynn Moore, who is a nurse with a focus in urologic oncology. We're going to be doing a deep dive in all things intravesical therapy. But why don't we start off with both of you telling the audience a bit about yourself, Meredith?
Yeah, I'm a nurse practitioner. I specialize in urologic oncology and run our intravesical therapy, work at a large academic hospital. We are doing everything. We're doing BCG, gemcitabine, docetaxel, Estrogen, Anktiva. So we got a busy practice.
Yeah. And Brynn?
Hey, I'm Brynn. I'm a registered nurse, surgical uro-oncology. I actually started my nursing career largely in home health and home hospice. So got interested in ostomies, and that kind of brought me into a practice that did a lot of ileal conduits. And now I love all things urology at this point.
Awesome. I just think, the intravesical therapy space and bladder cancer space more generally too, it's one of those spaces where, there's just a great need for multidisciplinary partnerships. We have patients who are dealing with a lot, even in those who might not be undergoing radical cystectomy, which is our bias. We tend to think that is the extreme. Intravesical therapy can be a really tough process as well. So I just wanted to take a few minutes, nurse practitioner, RN, different roles. Let's kind of break down how you interface with these patients more specifically. So Meredith, why don't we start with you?
For me, with our intravesical patients, I'm doing all of the clinical stuff, the catheters, giving the medications. I manage all of the side effects associated with intravesical therapy, treat UTIs, do all of that, which takes a big load off of our doctors, I think, to not have to get those constant messages and calls about side effects from BCG or whatever they're getting. And then another big part of what I do is their coordination of care. So making sure in a perfect world, they would get scheduled for their 6 BCG treatments and their cysto, but that doesn't happen. So making sure everyone has their follow-up, their cystos, their TRBTs all scheduled. So it's really I'm really the clinical person, care coordinator, kind of the glue to get all those patients where they need to be.
Yeah. Again, lots of moving parts like you alluded to. So
a lot of moving parts.
Exactly. Brynn, what about you?
Yeah, so I also do all of the installations, so doing the practical piece of it. So by the time the patients see me, they've had a lot of conversation about what's going to happen. But I do find it gets overwhelming. We did talk a little bit before about it's not that it's in one ear, out the other. It just is there's only so much space. There's a whole emotional component to it. And I think there's a lot of anxiety in the unknown. So I really do try to put as much effort as I can into pre-counseling strictly on what your day is going to look like. No surprises when you come in. And there is often some wait going through the pharmacy. We're dipping urines. We're coordinating with the shortage. That's a whole separate beast of its own, managing split doses, those sorts of things. So letting the patients know, hey, nobody forgot about you. It's a lot of wait for what can be kind of anticlimactic for the actual installation. Know what you're experiencing is not unexpected or, ooh, that is different a little bit. So just setting expectations so they really feel like you're doing this with them, not to them, a true partnership in the process.
That's such a great point. And I think from your perspective, being the person who may even be placing the catheter, doing that, that's a sensitive area. It's a sensitive process to go through. I tell my patients when I'm preparing them for bladder installations, you will have a Foley catheter in your bladder. And a lot of people don't take that news well. And so, I think your phrasing right there about doing this with them, not to them, is really key. What are some things you've learned in how to help assuage that patient anxiety or pain even, or discomfort during the process?
That it is so personal and so individual, and you kind of have to let them lead a little bit. That's really difficult for a lot of us in medicine. We are not used to letting the patient take the reins in a sense, but obviously, we're not going wild with it. They're not catheterizing themselves or telling you step by step. But some people want to know, as you go along, what the next thing you're doing, why you're doing it, as you're prepping them. There are some people at every single thing is deep breath. This is going to be a little cold. This is going to be a little bit of pressure. This is going to be, I'm cleaning right now. I'm preparing right now. I'm lubricated, step by step. Some people, they just want to talk about pickleball this weekend. They want to even for their very first one, some people just want to chill. Some people just want to take nice deep breaths. And you really have to be ready to pivot, because this is another part of our day, but this is a really sensitive experience for them. So you might it's hard, you get through the day most efficiently when you sort of get in a flow and a routine. But my flow and routine has been just be ready to let them show me kind of what way they want to go, and just roll with that. Really, as much as possible, let them take the reins, because they're having an experience that I am not, and just keep that really front of mind, even if it's just another day for me.
Yeah, absolutely. Now, you each have your roles. They interface with the urologic oncologist or the urologist. Let's dig into what that multidisciplinary team looks like from a practical perspective. So, Meredith, if I see a patient and we determine that intravesical therapy is going to be the next best step, where does it go from there in your experience?
First thing is I have a great group of doctors that I get to work with. So, it's an open communication constantly. They respect me. I respect them. They trust me is a big thing. So patient has TURBT, we get path, doctor says, let's start intravesical therapy. And then as soon as we get that message, myself and my nurse, she's like the puppeteer to all of this. She's really running it, gets them scheduled, and then get going. It's really the scheduling. That's the easy part. It's everything Brynn was talking about is the hard part of the managing the anxiety and the emotional, and every patient is different. And then also managing side effects. That's the big thing.
Yeah. And we'll get into that counseling piece in a minute, but I know that not every practice may have a nurse practitioner.
Right.
And so, I want to hear from you, Brynn, in your experience, from the RN side. Let's say there is not a nurse practitioner who's taking ownership of that intravesical therapy process. What does it look like from your perspective? Is it the physician reaches out and says, hey, I want to start BCG on this patient? Where do they go from there?
Yeah. So, I've worked in 2 different clinical practices where we're doing BCG and other intravesical therapies for patients. With the BCG specifically, I know you guys have talked even a lot on this podcast just about it's a whole world just managing the shortage, splitting doses, those sorts of things. And unfortunately, there does need to be some clinical review of prioritizing people who are a little bit higher risk,
right,
and people who really need the BCG up front. We also do, where I am now, a lot of clinical trials. So there's a lot of management that goes into all of that is even a much bigger effort than just, hey, I have a really good relationship with, the attending who is ordering this.
Yeah.
It goes beyond that, even into our front desk scheduler, who coordinates all of this, works really closely with me on it. We have leads, in different pieces in the pharmacy who really have to be communicating with us on a regular basis about what does our stock look like? Has there been an interruption in things, right? Because as Meredith alluded to, like in a perfect world, we do our 6 weeks, we plan our cysto, things happen with management and with side effects and those sorts of things. So it's really important that the lines of communication are open between a lot more people than you would even think. There's a lot of hard work that goes into making sure that these patients have a tailored experience, essentially.
And highlighting the pharmacy. I think, they really do a lot. And we're lucky that we have one pharmacist, this is what she does. And we are, on those days, we're constantly talking and know what's going on, what the other one is doing.
Yeah. And I think you guys have alluded to this, but open communication, having multidisciplinary meetings when you're going to pilot some of these new therapies, I think is critical. Understanding the workflow. For example, a gemcitabine docetaxel installation looks very different from a BCG installation, both in terms of process, but also time required, many moving parts there. So I think that piece is really, really key. We talked about this a bit earlier when it comes to helping patients understand what the experience is going to be like. You said this, you alluded to it. Sometimes when we're counseling and reviewing pathology results, as physicians, we outline the intravesical therapy process, but it is a lot for the patient to take in. You might be giving them a cancer diagnosis for the first time. In addition to that, they're processing the fact that they are going to need a catheter placed. What resources are out there that we can all use, whether it's the urologist, the nurses, even some of the office staff? What do you find patients really appreciate, Meredith?
Yeah, resources that we use all the time. Beacon, the Bladder Cancer Advocacy Network, they have great patient resources, the books that we have in clinic. But then I also was just doing my own searching, and their resources are online are amazing. They break down each different therapy. So there's BCG, gemdosi, explaining each one, why you're getting in terms that not a doctor could understand.
Yeah.
Why they're getting it, what it does, what it's going to look like. We also have sheets for the patients, and that's something that we're not great about giving, forget to give it. Oops, they didn't get their sheet today. And so we need to be better about that. And those sheets need updating. But I think Beacon is the best for as far as patient resources.
Yeah. Brynn, what about you? Any resources you like to point patients towards?
Yeah, I mean, I love the shout out to Beacon. And again, having started in home health and seeing like actually how a patient is processing, managing their own care, what you thought they had a great understanding of in the office, what that actually looks like in their home has given me such an interesting perspective on everybody's different, everybody learns differently. And Beacon definitely, they have, the written materials, they have an incredible user-friendly website, and they have a lot of videos too. Like, so if that's a little bit more, if that speaks to patients a little bit more, makes things a little bit clearer, that's ideal as well. But I also really like to utilize our front desk. Like I said, our schedulers and myself, we kind of knowing the process, the questions to ask about if you're incontinent, if you're going to have difficulty giving a sample, if you're going to have to stay with a capped Foley, all those sorts of things about then plugging it in the right way to make the day flow and being a direct resource for the patient before they even come in about what the day is going to look like and some of the things that might be out of the ordinary, and just giving that nobody knows your clinic and your clinic flow like the people who are working in it. So really letting them know step by step what the day looks like, I think, really helps assuage a lot of anxiety for a lot of these patients.
Yeah. Let's talk a little bit about side effects, because that can be quite a challenge in patients who are starting their intravesical therapy journey. So Meredith, why don't you tell me first, what are the most common side effects that you see in these patients?
Probably the lower urinary tract symptoms: frequency, urgency, dysuria, hematuria, incontinence. I mean, it could be across the board. And then definitely with BCG, Adstiladrin, Anktiva, and even gemdosi, I see some low-grade fever, flu-like symptoms. I mean, definitely the BCG. We all know that. And so right now, we're very reactive with managing the side effects. My goal is to get us much more proactive and assessing lower urinary tract symptoms prior to starting, because most of these patients are already having some frequency, urgency, dysuria. And then we start putting agents into their bladder, and that all gets so much worse. Really, and one thing I should note is it's so emotional for patients. If they're, we tell them, okay, hold it for 2 hours, hold it for 1 hour, and they hold it for an hour and 45 minutes, they feel like they've failed a lot of times. And so it's a lot of like, that's okay, you did great, that's all you can do. And talking them through that, and here are things that we can do to make it better. Like, you're going to be okay. It's a lot of talking through the emotions of it, and that there are things that we can do to help.
Yeah. I want to stay there for a second. I really like that. So, patients are feeling a sense of personal responsibility because they're saying, I need to hold this agent. Brynn, do you find that? And how do you help counsel patients through some of the pressure they're putting on themselves when it comes to that aspect of intravesical therapy?
Yeah, 1,000%. And that is also why I do think, listen, this is ideal and not always possible, but like continuity of care is so major. Messaging is so major. Seeing the same person every week, again, not always in every setting necessarily feasible. However, if you feel like you have a relationship with this nurse or this nurse practitioner or this provider who is, taking you through the steps of this treatment every single week, for me, it then is very, very helpful and very easy to then recall, like, hey, we did an hour and 45 minutes last week. We did an hour and 40 minutes this week. Like, you are doing great. This is not something that went left. This is not something that you did wrong. We are doing the best that we can. And every single week, no matter the patient, I do remind them that like these are cumulative side effects. Yeah. So every week, everybody is going to have a harder time holding. That's just what it is. And that is the expectation. And we're here for you to help in whatever way we can. And if that's looking at adding in a new medication, or let's talk about what you ate and drank last night and into this morning, those sorts of things, like just sort of trending week by week. Again, the patient feels like a partner in that process. There are modifiables. It's really empowering to talk to them that like there are things that we can't control, but there are things that we are. So let's talk.
That's great. And so, Meredith, what are some of those medications that you find very helpful? When do you give it? You mentioned trying to be proactive. Is there a pre-medication protocol that you've established?
So ideally, there would be. And that's what I'm working on. But again, right now, as it is, it's patient gets their first treatment. And let's say they have, they aren't able to hold it. They have horrible lower urinary tract symptoms. And then I tell them, send me a message over the weekend. I'll see it by Monday, and I'll get you on something that whatever we need to get started on. Typically, starting with the anticholinergics, I try to stay away from oxybutynin, given all of the recent blood-brain barrier crossing with that. So typically, I'll start with trospium. Some patients, if it's everyday frequency, urgency, I say, we're just going to start taking it twice a day, every day. Some patients just need it to help them hold their therapy. So I'll have them, if they're getting their treatment on a Friday, I'll have them start it Thursday and then take it through the weekend and then can come off of it if they do okay otherwise. A lot of the men need to start them on Flomax because then that's something I worry about. You cath them and every week they've got 300, 400 in their bladder. And then I worry about that long term of that, but also, okay, are you actually peeing out the BCG fully? So trospium, Flomax, this is a really big thing I think that we can do better with is a lot of the women postmenopausal are getting recurrent urinary tract infections. Things are just really uncomfortable for them down there. So I start a lot of the women on transvaginal estrogen cream. I think if starting them, even a month before they come for BCG would be a perfect world again. So those are the big things: trospium, Flomax, estrogen, whatever they need.
I share your sentiment about women and starting vaginal estrogen. I'm trying to be more proactive in the bladder cancer patients I see who may be attributing some of their lower urinary tract symptoms to the bladder cancer, when in reality, there's probably some piece of peri-post-menopausal symptoms going on. And I think you're right, starting vaginal estrogen early will definitely help with some of their symptoms that may not necessarily be coming just from their new diagnosis of bladder cancer. Brynn, anything else that we missed there that you've found helpful in your patients?
No, I mean, I just want to call back. I know that now I'm like, it's all three of us, but as women, I mean, it's even been a great topic of conversation this weekend. Just like, it's something we want to and need to get better about because we've just not talked about it for so long. So yeah, I mean, just constantly calling awareness and attention to this. I think we do have things like, I don't want to say like, down pat for our male patients, but there's been a lot of trial and error there and a lot of conversation around it. That our women who are coming in for this, like I'm glad that we're getting a little bit more attention on managing them coming in, because I do find they can also be the ones who are hardest on themselves when they have difficulties holding, and it can be, they're a little bit more used to like sensitive exams and those sorts of things.
That's right.
Which is, helpful to us, and it opens the conversation a little bit more. But yeah, I do think there's more we could be doing to tailor things to them that I'm glad is kind of going in that direction.
Yeah. We mentioned incomplete emptying in men, but women have a lot of incontinence, and there may be a challenge there that is different. So I love that. Meredith, go ahead.
I was just going to say one thing I didn't mention was also using Valium suppositories. Again, that can kind of be a trial and error. I've seen, the patient can't hold their treatment at all. So then the next week I get them started on Valium suppositories. But with that, then they have to have a driver, and actually getting that prescription can be tricky sometimes. So there's logistics that go along with that, but that's another really helpful tool.
Yeah. I know you have a couple tricks up your sleeve that have worked really well for my patients who have trouble holding. So why don't you share some of those? Because I think everyone can learn from that.
Yeah. I've learned a lot of tricks along the way. Patients who, and this specific patient you're talking about, there's some dementia going on. And I think she thought she actually was supposed to pee.
Yeah.
I don't think she totally understood she's supposed to hold it, no matter how many times we tried to talk that through. So what I do with her is I place the Foley, drain her bladder, she's getting gemcitabine docetaxel, put the gemcitabine in, attach a bedside bag, and then hang the bedside bag way above her head as high as I can to an IV pole. And then that way, if she tries to void or if she spasms, the medication goes up the tube, and then when her bladder calms down, it comes back down into her bladder. And so I've used that on a couple patients now, and it worked great for her. She had some recurrences, and then we started doing that, and her bladder was clear.
I was going to say, it's amazing. So she struggled for the first induction course. I did another TURBT. As you mentioned, there's some comorbidities there, so we wanted to give it one more shot before we talked about radical cystectomy. And after that trick, I looked in her bladder and she was recurrence free. It was amazing. So I think there's like a really important lesson here that there are things we can do to help optimize contact time. It really does matter. And when you have a patient who may not have tolerated the intravesical therapy, it's important to try to think outside of the box. We as surgeons may not be doing that because we may not be in the room when some of those conversations are happening. And so this is just one example of why these multidisciplinary, conversations are so important. Because I remember you telling me about your trick and I said, interesting. And I was really excited to message you after. And I said, oh my gosh, it worked.
I was so happy because she's had a hard time.
Exactly. It worked.
But that trick is great. But then I even have a guy right now and he still leaks around. I hang the Foley, he still leaks around. So
we just do the best we can.
We do the best we can. Yeah.
That's right. So, Brynn, we alluded to this a lot of times. Some practices struggle with the BCG shortage. That can be a logistical challenge. Tell me a bit about your practice workflow as it relates to the way you've been able to schedule patients, optimizing them in a time where BCG may not be in full supply.
Yeah, especially when this first started and we had to go to split doses for, pretty much everybody. It was a little bit of trial and error. Unfortunately, that started in 2019 for our practice. And then 2020, COVID hit. There's a whole separate thing around how many people we want in the office at one time. So we're doing logistics with two different things. And what ended up happening is, since patients were paired, if there's an issue with one, it really can turn into an issue with the other, whether that's gross hematuria, whether it's UTI symptoms, whether it's somebody just running incredibly late. It can really throw the other person, and it just turned it into constant management of, working with these different issues on the fly, and then patients even kind of getting a little frustrated with each other sometimes. So what we ended up doing was just turning it into everybody coming in at the same time, on 2 designated days that we worked with the pharmacy on, and then all hands on deck with our nursing staff. So everybody comes in and we just start the flow, collecting urine, dipping things, assessing for symptoms, bringing everybody in, splitting up as it goes. And then that way, if one person kind of falls off, we can adjust a little bit more easily, because there's not one group where you're like completely reliant 50-50 on what's going on that day. I mean, that's so unpredictable and uncontrollable. And honestly, what ended up happening then is you have these groups of people who are coming in. It's all the same people together every week for 6 weeks, sometimes exactly, sometimes just overlapping. And, they've got their little dinner clubs, they've got their text chains, they've got like somebody who actually really understands what they're going through. Because, like we talked about before, we're having not at all the same experience as these patients. Here's a group of people who are, and it actually completely changed the flow of the clinic, the vibe of the clinic, even like the patient's attitude towards the whole thing. And like, that seems light and fluffy, but it goes a long way. We talked a lot about how frustrating it can be, how scary it can be. And it just was a much more supportive, kind of sunny for something that can be dark. Like, it changed the outlook for a lot of people, and it really optimized our workflow at the same time. It was total win-win.
It's such a great story, right? The clinic waiting room is a special place. Mm-hmm. I've had patients tell me, I was talking to somebody out in the waiting room and they shared with me this is what they're going through, and we had a great conversation. Those meaningful discussions, we just can't provide that perspective to our patients. So I love hearing those stories and the little support groups that form impromptu. That's so awesome. Meredith, why don't you tell me about the logistical workflow of your practice's BCG, or I should say intravesical therapy clinic?
Yeah. A lot of logistics, for sure. So I'm doing 50 to 60 intravesical therapies a week, but we do it all on Fridays. I do the gemcitabine docetaxels in the morning, because that's more, they have to sit for longer. And then I do BCG, Adstiladrin, Anktivas all in the afternoon. But we've got it to a well-oiled machine at this point. And I mentioned my nurse earlier. She runs the show, and she assigns. I have my lead nurse, and then a group of probably 5 to 6 nurses, and we have one bringing patients back, getting vitals, one dipping urines, one flipping rooms, one coming in with me, cathing, being another set of hands with me. So we've got a well-oiled machine, and to do 50 to 60 patients, it has to be. And then, there's a lot of hiccups that can happen. That's for sure, and that's part of it. And that's where I come in and manage and deal with those, what we don't expect. Somebody leaking, someone having UTI symptoms, constant communication with the pharmacy, like I said. Yeah, it's a lot of logistics.
Yeah. And something I'll just highlight for the audience here, you alluded to 2 days, you have 1 day that's kind of jam-packed. I think it is important to try to condense a lot of these workflows, because the workflows for intravesical therapy, particularly for some of these newer agents that require more pharmacy oversight, it can definitely get in the way of the flow of a regular clinic day, and that can frustrate everyone. So I think for folks who may be newer to practice, or perhaps ramping up in some of the novel agents that are different than BCG and require, more partnership with pharmacy, specialty pharmacy, things like that, try to optimize and try to carve out a specific time that won't interfere with the usual office visit clinic.
Yeah, I totally agree. Trying to condense it all into one. And of course, there's always patients. I have a 95-year-old lady, and her driver can't come Fridays, so I put her on my Tuesdays. And, I'm always going to make it work for those one-offs, but trying to condense them into one day definitely makes a difference. And it just puts us all in that mindset of, this is what we're doing. And I think Brynn, you mentioned just the continuity of the care is so important. I hear patients all the time, Meredith's here today, right? Meredith's here. And just seeing the same faces in such a scary situation, I think it makes a big difference. And, seeing the same nurses and, nurses will see those patients coming down the hall and stop and chit chat for a while. So I think it makes a big difference. And what we hear all the time from patients is we make a really awful situation okay.
Yeah. Yeah.
That they know it's good, it's horrible, but we make it as good as it can be.
Yeah.
And that means a lot.
Yeah. Yeah. That's awesome. There may be a lot of nurse practitioners or RNs who don't have experience in this world of intravesical therapy administration, clinic workflow, all of that. So, Brynn, from your perspective, what is some advice you have for nurses who may be new to this space? What resources do they have to go learn about, some of these conversations?
Yeah, I think this is all part of a bigger conversation around interdisciplinary care, interdisciplinary planning, and bigger operational overviews. But I am very lucky that when I started in this space, I was somebody who didn't know anything about it. And I had managers and peers and physicians who really championed my ideas and who created a safe space for me to ask questions. So I think any nurse who leads with curiosity, you're really going to be great and you're really going to be fine. And there is in nursing specifically, such an amazing focus on teamwork that if you show the interest, there are always going to be people who are happy to let you shadow them, to connect you to this, that, or the other person, to point you towards your resources for I constantly say, I far from know the answer to everything, but I can tell you where to find it. I can tell you where to start. I know where I'm going to look. So really just being open-minded, asking questions, and really prioritize knowing what your resources are and who your resources are, letting go of the feeling like you've got to know it all. It's just not ever going to happen.
Yeah, absolutely. And leaning on the physicians you work with too.
For sure.
I think that's important. And the onus is on us as physicians to create those spaces, like you said, where we can have open, honest communication, and we're always welcoming questions. Even having some of the nursing staff who may be running the intravesical therapy clinic spend some time with us when we're having conversations in the office, prepping
Absolutely.
patients. I think there's a lot of shared learning that can happen there. Meredith, what about you? Nurse practitioners who may just be getting into the urology space, or maybe even those who have urology experience who may be getting pulled into this new world. What's your advice for them?
Yeah. Right after bladder cancer, APP training in urology is my next love. And there's so many resources available that people just don't know are available. A big one is the AUA, of course. Of all the guidelines, all of that. But much more digestible material is the core curriculum. Yeah. It has great resources. And that's not going to tell you how to logistically do intravesical therapies, but more of the why. I think for APPs, it's really important to understand the pathology, the disease process, the scheduling of each therapy of induction and maintenance and all that. So one thing I encourage is the core curriculum. Also at our institution, tumor boards. I always encourage our new APPs whether they're going to be in oncology or just spending some time with us, to come to tumor board. Such great learning can happen there. I think when I first started, I found tumor board really helped with imaging. I really learned a lot on how to read scans. So taking advantage of what your institution has. We're fortunate that we have a lot of resident teaching conferences and those things. Again, shout out Beacon. I think even though that's really for patients, I think providers can take away a lot from what Beacon has to say. And as far as logistical stuff, I think nurses, APPs, you should be, if you're in urology and doing urologic oncology, you should be so confident with catheters.
Yeah.
New APPs, I try to get their hands on as many Foleys as possible.
Dear 10,000.
Yeah. Yeah, because, we have a lot of difficult Foleys, and on those days, it's me who needs to deal with that and get that catheter in. And so that's a big thing, is be so comfortable with Foley catheters.
Yeah. Same advice we give our residents.
Yeah. Just as many as possible.
And if I may, I mean, shout out BackTable a little bit too. Like, I mean, for me as a nurse, because I know there is a lot that is geared here towards physicians or advanced practice providers, but like to your point, the flow of clinic, you can't always be in the room. Not everybody's open to you shadowing them. To hear like the little tips and tricks that you guys have been, even this is how I phrase it to a patient. You know, we don't always get to hear that. We're not in the room. And that is very helpful. And I think it goes both ways. You know, we can all learn the different things, like I said, that sort of click for different patients. You just need to hear it and hear how it's received. And that's been, you know, it's been a really great, for me, like peek behind the curtain, you know, time that I don't always get to hear physicians talk about kind of like, yeah, their tips and tricks for patient education. There's plenty for all of us to learn. So this has been like an awesome experience just to get to listen to physicians speak to each other about like the different way that they make it work.
Yeah. Well, we appreciate that. And that's the mission here. And so I think you're right. I think digesting this information outside of necessarily the written materials that you find on the core curriculum or in a textbook, it's important to hear how things are phrased specifically, how patients receive that, to your point, all really important. I just want to wrap up by saying multidisciplinary collaboration is so critical in so much of what we do in urology. We lean on each other, and we're just thrilled to have your voices on the podcast so our physicians can learn from you both. So thank you so much. We appreciate diving into this important topic.
Thank you.
Thank you. This is awesome.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.